Most people finish a walk and consider the work done. From a cardiovascular standpoint, they are correct. But the muscles that drove every stride, the calves, the hamstrings, the hip flexors, the lumbar chain, have spent 30 minutes contracting without once being asked to do the opposite. The first thing I ask patients who come in stiff after regular walking is always the same. What do you do after the walk ends? The answer is always nothing. The body keeps that account. It does not forgive it. Over weeks and months, that one-directional mechanical work produces progressive shortening that tightens joints, compresses discs, and pulls posture forward. People call it getting older. I call it an incomplete protocol. Subscribe and hit like right now. What follows, nobody tells you at your next appointment. There is a specific mechanical problem that walking creates and that almost no one addresses. It is not complicated. It is not controversial. It is simply the product of how walking works as a movement pattern, and understanding it changes what you do for the rest of your life every time you finish a walk. Walking is a concentric dominant activity. That is a clinical term, and here is exactly what it means. During a concentric contraction, a muscle shortens as it generates force. Walking creates, and that almost no one addresses. It is not complicated. It is not controversial. It is simply the product of how walking works as a movement pattern, and understanding it changes what you do for the rest of your life every time you finish a walk. Walking is a concentric dominant activity. That is a clinical term, and here is exactly what it means. During a concentric contraction, a muscle shortens as it generates force. When your calf pushes off the ground with each stride, the muscle fibers shorten. When your quadriceps extend your knee, the fibers shorten. When your hip flexors pull your leg forward into the next step, the fibers shorten. This happens continuously, rhythmically, hundreds of times per mile, with no corresponding lengthening phase built into the movement. The muscles contract, they never stretch. Here is what that asymmetry produces over time. Muscle fibers are composed of smaller contractile units called sarcomeres. Under repeated concentric loading without an eccentric counterbalance, sarcomeres adapt to their shortened functional length. The muscle tissue does not simply feel tighter, it restructures toward a shorter resting length. This is not soreness. This is not a temporary state that resolves with an hour on the couch. This is a progressive mechanical shift that accumulates across days, weeks, and months of walking without a corrective protocol applied afterward. The consequences move up the chain. First, the calves. When the gastrocnemius and the soleus, the two muscles of the calf complex, remain shortened after every walk, the Achilles tendon, the large cord-like tendon connecting the calf to the heel bone, stays under chronic tension. That chronic tension increases compressive load on the plantar fascia, the broad connective tissue band across the bottom of the foot. The result is plantar fasciitis. Not because the person walked too far, because they never addressed what the walk did to their calves. Second, the hip flexors. The Iliopsoas, the deep muscle connecting the lumbar vertebrae directly to the top of the femur, shortens with every forward stride. When it stays shortened, it pulls the lumbar spine into an exaggerated anterior curve, a forward arch, and increases compressive load on the intervertebral discs at every lumbar level. Third, the hamstrings. Chronic hamstring tension compresses the sacroiliac joint, the junction between the base of the spine and the pelvis, and flattens the natural lumbar curve from below. Fourth, the deep hip rotators. When they tighten, they generate deep gluteal pressure that radiates down the back of the thigh in a pattern close enough to sciatic nerve symptoms that walkers spend months pursuing the wrong diagnosis. The 5 primary muscle groups that accumulate this shortening in walking are, in clinical order of consequence, the calf complex, the quadriceps, the hip flexors, the hamstrings, and the deep external hip rotators. These 5 groups drive every stride. They are also the most neglected after every walk ends. Most people know, in a general sense, that stretching after exercise is a reasonable idea. That is not the same as knowing which stretch targets which muscle, why that muscle shortens specifically during walking, what pathology develops when it is left shortened chronically, and exactly how to position the body to load the tissue correctly. That distinction between knowing stretching is good and knowing what each stretch does and why is the difference between a 5-minute protocol that produces real structural benefit and 5 minutes of approximate movement that
accomplishes very little. Your appointment covers the walk, step count, duration, heart rate, footwear. It does not cover what the walk does to your muscles when it ends, or what accumulates over years of ignoring that question. That is not an oversight by any individual clinician. It is simply not where the system's attention is directed. The system is structured around treating the consequences of neglect. Plantar fasciitis gets an injection. Lower back compression gets imaging. Deep gluteal pain gets a referral. None of those interventions address the 5-minute protocol that makes each of those diagnoses significantly less likely to occur. That is exactly why this channel exists. 7 stretches directly counter the specific shortening pattern that walking produces. Each one targets a precise muscle or muscle group. Each one has an exact position, a specific hold duration, and a mechanical reason for both. Performed immediately after every walk, in sequence, they take between 5 and 7 minutes. What follows is each one in clinical order with the full mechanism and the exact instruction required to perform it correctly. The first stretch addresses the calf complex, and it is the highest clinical priority on this list for a reason that is entirely mechanical. The gastrocnemius and the soleus, the 2 muscles that make up the calf, are the most aggressively contracted muscles in the walking gait cycle. Every push-off phase loads them concentrically. Every stride repeats that load. By the end of a 30-minute walk, these 2 muscles have contracted hundreds of times without once being asked to lengthen. The consequences of leaving them in that shortened state move directly up the chain. First, chronic calf tension overloads the Achilles tendon. Second, that Achilles tension increases compressive load on the plantar fascia. Third, restricted calf extensibility limits knee flexion range and alters gait mechanics at the knee joint itself. Most plantar fasciitis cases I see are a calf stretch deficiency, not a foot problem, a calf problem. The reason this stretch requires 2 positions is anatomy. The gastrocnemius originates above the knee joint on the posterior femur. The soleus originates below the knee on the posterior tibia. A straight knee loads the gastrocnemius fully but barely reaches the soleus. A slightly bent knee releases the gastrocnemius from peak tension and allows the stretch to load the soleus directly. Both positions are required. Stand facing a wall. Place both hands flat against it. Step 1 foot back. Press the heel firmly into the floor and hold with the knee straight for 30 to 45 seconds. Then soften that same knee to a slight bend and hold again for 30 to 45 seconds. Switch sides. Do not bounce. The heel staying in contact with the floor is the stretch. The moment the heel rises, the stretch ends. The second stretch targets the quadriceps, and specifically the rectus femoris. It is the only one of the 4 quadriceps muscles that crosses both the hip joint and the knee joint. That anatomical fact determines everything about why this muscle becomes problematic in walkers. Because it crosses 2 joints, it shortens during walking in 2 places simultaneously. At the hip as the leg drives forward, and at the knee as the leg extends. When it remains shortened, it pulls the pelvis into anterior tilt, a forward rotation of the pelvis, and that tilt directly increases compressive load on the lumbar vertebrae by exaggerating the lumbar curve from above. Not general lower back discomfort, measurable disc compression produced by one specific correctable mechanical condition. Stand on one leg and draw the opposite heel toward the buttock, holding the ankle with the hand on the same side. The critical technical point is pelvic position. Most people perform this stretch with the pelvis already in anterior tilt, which means the rectus femoris is never fully tensioned across both joints simultaneously. Actively tuck the pelvis, drawing the front of the hip backward and flattening the lumbar arch before adding the knee bend. Hold 30 seconds per side. That pelvic position is not a form preference. It is the loading condition that determines whether the stretch reaches the tissue it is designed to reach. The third stretch addresses the Iliopsoas, the deep hip flexor that connects the lumbar vertebrae directly to the top of the femur. Clinically, this is the single most significant muscle for lower back pain in walkers, and it is the least visible and least understood. First, it is not a surface muscle. It runs through the interior of the pelvis. Second, it contracts with every forward stride to pull the leg through. Third, when it remains chronically shortened, it does not merely create hip tightness. It pulls directly on the lumbar vertebrae from its attachment points and drives the spine into an exaggerated anterior curve, increasing disc pressure at every lumbar level. The hip feels tight, the back pays the price. Kneel on one knee, step the opposite foot forward, and shift the hips forward until tension is felt at the front of the kneeling side hip. Before adding any forward shift, engage a posterior pelvic tilt, the same gentle tucking motion used in the quadriceps stretch. Without that tilt, the stretch loads the front of the hip capsule but fails to fully reach the iliopsoas itself because the lumbar curve that the muscle is pulling on remains uncorrected. The tilt is the condition. Hold 30 to 45 seconds per side. The fourth stretch targets the hamstrings, the muscle group running from the sit bones at the base of the pelvis to just below the knee. The hamstrings are eccentrically loaded throughout the walking gait cycle, meaning they generate force while lengthening during the swing phase as the leg moves forward. That repeated eccentric demand accumulates chronic tension in the tissue that, left unaddressed, does two things simultaneously. First, it compresses the sacroiliac joint from below. Second, it progressively flattens the natural lumbar curve by pulling the pelvis into posterior tilt. The result is a spine that loses its shock-absorbing architecture from both ends at once. The supine position is the correct position for this stretch, not standing, not seated. Lying on the back with one leg raised and supported, either by the hands behind the thigh or a strap around the foot, removes the compensatory pelvic movements that standing and seated hamstring stretches allow. In a standing position, the pelvis rotates forward to simulate the sensation of the stretch without the hamstring fully lengthening. On the back, the floor stabilizes the pelvis and the stretch loads the muscle directly. Raise one leg toward the ceiling. Keep the knee as straight as current tissue length allows without forcing, and hold 30 to 45 seconds per side. The sensation belongs in the belly of the muscle along the back of the thigh. If it concentrates behind the knee, reduce the angle slightly. The first 4 stretches address the leg chain. The next 3 go deeper. The 5th stretch targets the piriformis and the 5 other deep external rotators of the hip, a group of small muscles sitting beneath the gluteal muscles that control femoral rotation in the hip socket during every stride. When they remain chronically shortened, they generate a deep, aching pressure in the gluteal region that radiates down the back of the thigh. That radiation pattern closely resembles sciatic nerve pain, closely enough that walkers spend months, sometimes years, pursuing nerve-related diagnoses and nerve-directed treatments for a condition that has nothing to do with the nerve. Not a nerve problem, a tight piriformis. The figure 4 position is the correct stretch for this muscle group because of the specific geometry it creates at the hip. Lie on your back with both knees bent and feet flat on the floor. Cross one ankle over the opposite knee and allow the crossed knee to fall outward. This combination of hip flexion, abduction, and external rotation loads the piriformis and surrounding deep rotators in a way that no standing variation reliably replicates. If no stretch sensation registers in this position, gently draw the uncrossed leg toward the chest until tension appears in the deep gluteal region of the crossed leg. Hold 30 to 45 seconds per side. The target sensation is deep, inside the gluteal muscle mass, not at the surface. The sixth stretch addresses the chest and the anterior shoulder, and its place on a post-walk list is a connection most walkers never make. During walking, the arms drive forward and back with each stride. That repeated forward arm drive concentrically contracts the pectoralis minor, a small muscle running from the front of the shoulder to the upper ribs, and the anterior deltoid, the front portion of the shoulder muscle. Both shorten with that demand. When they remain shortened after the walk ends, they reinforce exactly the rounded shoulder posture that compounds every other postural problem walking produces. First, the shoulders pull forward. Second, the chest compresses, and the diaphragm, the dome-shaped primary breathing muscle below the lungs, cannot fully descend. Third, the head shifts forward of its neutral axis over the spine, and the load on the cervical spine multiplies. Not because of the walk itself, because of what the arms did during it, left uncorrected afterward. Stand in a doorway. Place both forearms vertically against the door frame with the elbows at roughly 90 degrees. Lean the body gently forward through the opening until a stretch registers across the front of the chest and the front of both shoulders. The doorway position works because it provides a fixed bilateral anchor that applies the stretch load through body weight and gravity rather than requiring muscular effort from the arms themselves. Hold 20 to 30 seconds. The sensation belongs across the chest and the front of the shoulders. If it concentrates in the shoulder joint itself, the elbows are positioned too high. Lower them slightly and the load shifts from the joint to the muscle tissue where it belongs. The seventh stretch addresses the lumbar spine, and it belongs here because of a mechanical reality that accumulates across every single stride of every walk. Walking is not a symmetrical movement in the lumbar region. Each stride produces a rotational force through the lower back as the pelvis and the shoulder girdle counter-rotate relative to each other to maintain balance. That rotational force is compressive load on the facet joints, the small paired joints at the back of each lumbar vertebra, and on the intervertebral discs, the cartilaginous pads between each vertebra. Over 30 minutes of walking, those structures absorb repeated compressive and rotational stress. A gentle bilateral rotational stretch after the walk moves them in a controlled, unloaded direction and allows that compression to release. The lumbar spine has been rotating under load for 30 minutes. Give it 2 minutes in the opposite direction. Sit in a chair with both feet flat on the floor and the spine upright. Rotate the entire upper body slowly to the right, using the hands on the armrest or the back of the chair for light assistance, until a stretch registers through the left side of the lower back and along the lumbar paraspinal muscles, the long muscles running alongside the spine. Hold 20 to 30 seconds. Return to center. Rotate to the left and hold again. The movement is slow, controlled, and entirely pain-free. This is decompression, not mobilization. The goal is not range of motion. The goal is releasing the compressive load the gait cycle imposed. 3 clinical principles govern all 7 of these stretches. They are not suggestions. They are the conditions under which the stretches produce the structural benefit they are designed to produce. The first principle is timing.
Perform these stretches immediately after walking while the muscles are still warm. Muscle tissue at elevated temperature has greater extensibility, meaning it responds to a lengthening force by actually lengthening rather than resisting. Cold muscle produces a fraction of the response and increases the risk of micro tears in the tissue. The walk creates the thermal window. The stretch must use it. The second principle is static hold. Do not bounce. Bouncing activates the stretch reflex, an involuntary neurological response in which the muscle contracts sharply to protect itself against rapid lengthening. That contraction works directly against the goal of the stretch. A sustained, still hold allows the stretch reflex to subside and the muscle to genuinely release into the lengthened position. Every hold duration listed is a minimum. Longer is better. Shorter is incomplete. The third principle is breath. Exhale steadily through each hold. This is not a mindfulness instruction. It is a mechanical one. Exhalation reduces involuntary muscle guarding, the low-level background contraction that muscles maintain even at apparent rest. As guarding decreases with each exhale, the stretch penetrates deeper into the tissue without triggering a protective response. Holding the breath sustains guarding and defeats the hold entirely. 5 minutes. That is the complete time cost of doing this correctly. Here is the full post-walk protocol in sequence. 1. Standing calf stretch against a wall. Knee straight, 30 to 45 seconds, then knee slightly bent, 30 to 45 seconds, each side. 2. Standing quadriceps stretch. Posterior pelvic tilt engaged before adding the knee bend, 30 seconds each side. 3. Kneeling hip flexor lunge. Posterior pelvic tilt held throughout, 30 to 45 seconds each side. 4. Supine hamstring stretch. Leg raised and supported, pelvis flat on the floor, 30 to 45 seconds each side. 5. Figure 4 piriformis stretch. Ankle crossed over opposite knee. Uncrossed leg drawn toward chest as needed, 30 to 45 seconds each side. 6. Doorway chest and anterior shoulder stretch. Forearms on the frame, elbows at 90 degrees. Lean forward gently, 20 to 30 seconds. 7. Seated lumbar rotation. Both feet flat. Rotate fully to each side with light assistance, 20 to 30 seconds each direction. That sequence, performed immediately after every walk while the muscles are still warm, is what separates walking that builds the body from walking that progressively shortens it, compresses it, and produces the stiffness and joint deterioration that most people accept as an inevitable feature of getting older. It is not inevitable. It is the accumulated result of an incomplete protocol repeated across hundreds of walks. Nobody in a clinic is going to hand you this. The appointment covers the diagnosis. It covers the prescription and the referral. It does not cover the 5-minute protocol that makes each of those diagnoses measurably less likely to occur, because prevention does not generate the same return as treatment. That is not a conspiracy. That is a structural incentive. And it is exactly why this channel exists. Subscribe to Dr. Waterling. Leave a like on this video. If someone you know walks regularly and comes home stiff, send this to them directly. And leave a comment below telling me which of the 7 stretches you have never done.